afternoon session. We hope you've enjoyed the lunch break and the chance to network with colleagues and with the speakers. I can see there are many great discussions. We will be able to continue them when we have the poster session and happy hour later as well. So we now have two more exceptional keynotes. It's my privilege to introduce our next keynote, Rachel Hilton. She is a psychiatry, mental health, a nurse practitioner with a PhD in implementation science at Vanderbilt. Rachel is deeply passionate about leveraging cutting-edge research and technology to advance precision psychiatry. And we're very fortunate that Rachel actually joined our center as the inaugural research nurse practitioner in precision psychiatry. And because of her passion and her dedication to the patients and her brilliant openness to these new precision approaches with imaging, the study that she will talk about, the big study, was possible. So please welcome Rachel to the stage. She will talk about targeting cognition in depression.
Hello, thank you for having me today. Today, I'm going to be talking about some work that we're advancing precision psychiatry and specifically targeting cognitive dysfunction and depression. And I have no conflicts to declare. The work I'm going to be talking about today is rooted in the unfortunate reality that the way that we currently diagnose and treat depression is failing many of our patients. We primarily rely on subjective symptom reports, as in asking patients how they feel. So psychiatric professionals such as myself will interview our patients, gather their symptoms, we'll make a diagnosis of depression, and then we carefully select from a pool of treatments that have been shown to generally help depression. And then we hope that it works. Unfortunately, it often doesn't. 60% of the time, the patient sitting in front of us will not see meaningful improvement when we trial a medication. And thus begins this cycle of trial and error. And in this process, our patients are losing time, they're missing out on life experiences and opportunities, and they're losing hope. I've seen this happen more times than I would like to admit. And to be frank, it's exhausting, and it can be profoundly sad to see. About 3 years ago, I had the opportunity to meet Dr. Leanne Williams, and I remember her talking about how in psychiatry, we lack tests for the direct organ of interest, the brain. So when patients have general physical symptoms, such as chest pain, in cardiology, we're able to test the heart, often scanning the heart. And the information from that scan will tell us at what's the root of the issue. And then the results from the scan will also directly inform what treatments we decide on. So Dr. Williams posed the excellent question, why couldn't we do this for emotional pain? I recognize that this opened up the potential to have truly informed, truly personalized treatment decisions for our patients based on what was actually going on in their brain. So I knew I had to join this lab. So the idea of subtypes is not necessarily new, but traditionally they've been based in symptom profiles. So you might have heard terms such as atypical depression or depression with mixed features. But when we look to see if patients put in these groups respond differently to different medications, they don't. It doesn't do much better than chance, as in these subtypes aren't clinically meaningful for treatment selection. With the MRI and computing technology of today, it's allowing us to shift to a biotype model, meaning take more direct and objective measurements of a patient's brain to delineate groups. So in the middle of the slide here, you see 6 brains. This is just an example of 6 circuits that our lab works with to help quantify and to delineate our biotypes. I like to tell patients that these areas of the brain are in charge of various things. And within circuits, it's areas of the brains that work together or talk with each other to dictate various things, such as how we think, how we process reward, how we respond to threat. Our hypothesis is that dysfunction, a patient's dysfunction in one of these circuits, is the primary driver of their depression. And so next is pretty simple. Our lab is looking to identify and test treatments that have mechanisms that directly target the dysfunction that we're seeing on the scans. In my 3 years with the lab, it's been my honor to see how this process can actually work for patients and improve our treatment of depression. So today I wanted to share some of those experiences with you. I'm particularly going to be highlighting some of the patient and participant experiences in a recent trial of ours and some of the outcomes for a trial that we so lovingly called the BIG study. So the biomarker study, the biomarker guided study for depression. So it's a pilot trial that we recently had that is the first prospective trial to treat cognitive dysfunction and depression. Most of you have probably heard of cognitive dysfunction or understand what that means. This is problems with how you think, right? So this can be problems with attention, memory, response inhibition, executive functioning. Our previous work, led by Dr. Laura Hack in our audience, identified what we call the biotype, cognitive biotype of depression. So in our work, we were able to link cognitive symptoms, cognitive behavioral performance, so how people perform on cognitive tests, and MRI data to identify a group of people that had a very specific profile of cognitive symptoms and depressive symptoms, had significant and specific deficits within cognitive performance, and within task-evoked MRI data, they showed hypoactivation and low connectivity within the cognitive control network. So specifically within two regions called the dorsolateral prefrontal cortex and the dorsal anterior cingulate cortex. So most of you have heard DLPFC and DACC. Our work indicates over a quarter of patients with depression likely suffer from this biotype. They unfortunately suffer from a worse symptom burden overall, and they're less likely to respond to antidepressants. So on this slide, that's our red group here. We were able to validate this biotype in another sample within a recent study of ours published in Nature Mental Health. Danny, a recent participant in our study, fit this biotype to a T. Danny was a 30-year-old software engineer that sought us out after hearing about our work. Like many bright people in the Bay Area, Danny's identity was really rooted in his intellect and capability. This guy loved the grind, loved working hard, and he was very proud that he had made it to a top tech company and what he considered the mecca of tech. But unfortunately, by the time he got to see us, he was really struggling at work. When I met with Danny, he had a hybrid role, but he wasn't going into the office. He was barely turning on his camera for Zoom meetings and really not getting out of his bed for a lot of meetings. Danny used to love engaging in complex problem solving, puzzle making. He loved games such as like Settlers of Catan with strategy, but he wasn't engaging in any of that. And this was particularly problematic because his job required that. He was afraid of losing his job. And he shared with us that he was suffering from passive suicidal thoughts. When I interviewed Danny, he displayed a particularly interesting symptom that we call psychomotor retardation or slowing. This is when patients' thinking processes and movements and speech are slowed down. So these patients think slow, they talk slow, and they move slow. And it's traditionally associated with severe depression. As you can imagine, he was pretty disturbed by these changes he was seeing in himself, and things such as the psychomotor slowing were really embarrassing to him in the workplace and embarrassing to him socially. Danny had tried 5 antidepressants without any major benefit. So another one of our participants was Angela. Angela was a full-time acupuncturist and a mom of 3 very busy children, and she generally loved the juggle. She knew that it was hard to juggle being a full-time clinician with being the default parent, but she was generally up for the challenge. This was a lady that she knew that she was going to remember to pay the bills, she was going to pack the kids' lunches, and she was generally going to be thought of as a dependable and solid employee. But in the past 3 years, the trains were really getting off the tracks for her. She was increasingly struggling with time management skills and organization. So forgetting things she normally wouldn't, like paying the bills, double booking her kids' social activities or their extracurriculars, getting more and more behind on her patient charting. She described this so aptly. She said it was a cycle of procrastination, overwhelm, and then shame. And what was particularly sad about Angela's case is you could see that she was losing trust in herself and that this was just eroding her self-confidence. Angela displayed something that we call thought blocking. This is where patients lose their train of thought. So you've probably had this before yourself or seen it in other people where you'll be in the middle of a story and then you just lose it. You don't know where your brain was going. This was happening to Angela frequently. As you can imagine, again, this was very much impacting her ability to work. It was quite embarrassing. And she shared with us that she was avoiding social situations because of this. Like Danny, Angela had tried multiple antidepressants without any major improvements. So we took Danny and Angela through our precision workup. This included MRI testing. So we did structural and functional. We did resting state data and task evoked data. They also did a computerized and standardized battery of cognitive tests. We used Web Neuro. And then we also did a very detailed symptom evaluation. This is taken from Danny's Precision Mental Health Report. So if you see on the left here, Danny's brain structurally looked great, looked healthy. In the middle, these are those circuits that I was talking about. Now, for our scoring system here, it's based off of the principle that within connectivity and activity, we don't want hypoactivation in regions, we don't want hyperactivation in regions, we don't want hypoconnectivity or hyperconnectivity. We want it to be just right, so to say, compared to norms. So for this scoring system, just right is around a 5. So if you look at Danny's circuit scores, all of them tend to be around 5. They appear to be healthy, functioning optimally, except for his cognitive control circuit. In particular, a reminder that this is looking at the DLPFC areas and the DACCs for the purpose of the study. This mapped onto a high cognitive symptom burden and also lackluster performance in our cognitive testing battery. Angela's results displayed similar trends. So when we think about the cognitive control circuit, Danny and Angela's symptoms start to make sense. When your brain's management system isn't functioning properly, your thoughts aren't going to be fluent. You're going to have a hard time keeping your thoughts straight. You're going to have a hard time filtering through extraneous or unhelpful information and making decisions optimally. When we thought about what sort of treatment that we wanted to use to directly target what we were seeing on the scans, we decided on an existing treatment in a novel way, guanfacine. So let me tell you, guanfacine is not a drug we would traditionally think of for depression. I remember when the PIs first approached me with the subject, and I thought to myself, a blood pressure pill for depression? Guanfacine is FDA approved for hypertension and also treating ADHD in children and adolescents. But when we look at the mechanism of guanfacine, it started to make sense. Guanfacine is what's called an alpha-2 adrenergic agonist, meaning that it stimulates alpha-2 receptors postsynaptically. And animal data shows that it binds very selectively to alpha-2 receptors in the dorsolateral prefrontal cortex, one of our areas of interest within the circuit. Animal data also shows that it increases, even single doses can increase activation in this area and increase network connectivity. Animal data also suggested that it has some antidepressant effects. Human data has shown that it improves cognitive function in people with Tourette's and mild TBI, and it's a safe drug. It's generally really well tolerated. What I liked most about it, it's highly accessible. This is an old drug, a cheap drug, and this is a drug that I could get to my patients today if I wanted to. So with Danny and Angela, we started them at 0.5 milligrams per day, titrated up to 2 milligrams, and they stayed there for about 8 weeks. I'm very happy to report we saw some really exciting things with Danny. So first off, Danny's brain changed in the areas that we wanted it to change, which was really cool, very exciting. He particularly saw increased activity in his left dorsolateral prefrontal cortex. We also saw that his cognitive functioning, particularly his response inhibition, significantly improved in our cognitive test, and his depression was in remission. He was rarely having suicidal thoughts. And this guy was back in the game. Okay. I mean, it was wonderful to interact with him. The psychomotor slowing had resolved. And what was cool to see is that this bright and witty individual that I knew was underneath that fog was finally being able to shine through. Angela also saw similar improvements. These are just some beautiful quotes that she shared with us. It's less overwhelming. I don't have to go through the procrastination cycle to get stuff done. I have a better sense of self. I'm more able to face problems and cope with them rather than think, oh, life is terrible and meaningless. Before it would be like, I know I'm going to miss something. Angela was rebuilding the trust with herself. And what was cool is she seemed like she felt like she was meeting her potential of a mother, wife, and clinician. So I'm happy to report that we saw these promising outcomes in our group at large. So when we looked at the cognitive performance data, particularly response inhibition and attention, we saw significant improvements. Within activity at the group level within the dorsal anterior cingulate cortex, we saw normalization of activity. And we also at the group level saw improvement in connectivity between the DACC and the DLPFC, so the cognitive control circuit. I think most impressively, we saw 64.7% of our patients reach remission of their symptoms, and 76.5% see at least a 50% or more improvement in their depressive symptoms. Now, this was an open label pilot trial, so obviously these results should be interpreted with caution, but I want to point out that we doubled the remission rate to antidepressants. I'm happy to report that the NIH also found these results very promising. And so we're grateful that they recently awarded us a very large grant to extend this work. So we're going to do a large randomized control trial testing guanfacine and standard antidepressants. We do a lot of good in psychiatry, and I wouldn't be in the field if we didn't. But we have much work to do to make sure that our patients get the right treatment, not the fourth, not the third time, but the first time. Our patients work so hard to feel better, and I'm just excited to give them a better chance. Now, thank you for listening to me talk. I very much look forward to talking in detail and answering any of your questions. On the left here, you'll see information about our lab and our center. In the middle are these beautiful people that work with the lab and make all of this work possible. And on the right is our research registry. You might have seen this. If you know anybody in your lives or in the community that might be interested in participating in our research, please have them scan the QR code or go to the link here. Thank you.
I might ask Rachel to come back to the podium. I'm sure there'll be questions. Thank you for a wonderful keynote. We do have time for a few questions, so please come to the microphone or raise your hand. So there's one at the back and one to the left. So,
sorry, I snuck off.
You guys found could be associated to this?
An environmental trigger for the cognitive issues?
This type that has been.
Yeah, I mean, I think that's an interesting question. We didn't necessarily measure for that in this pilot trial. I would say, you know, being clinical lead on this study and working with these patients directly, each of them had major stressors in their lives, right? But I think what's going to be exciting is that in this future study, the Ph.D. study that I showed a slide for, is we're really going to have a sample that's going to be large enough to track for these things and look for patterns.
That's amazing, because we know conditions like COVID, some of them can develop long COVID. So
yeah. So thankfully in the Ph.D. study, I think we'll be able to answer that question. Yes, in the back.
These subjects left hemisphere dominant?
I'm not sure. I would think so. Yes.
Okay. And then the second question is, They were both on standard antidepressants in addition to the guanfacine?
This is a great question. So as a part of this trial, all participants washed off of standard antidepressants. So this is one of the reasons I forgot to mention that we were very excited about these trials, because this was guanfacine and guanfacine alone.
So guanfacine was sufficient to treat their affective symptoms as well as the cognitive?
Absolutely. Yeah. So who would have thought guanfacine as an antidepressant? But
Who was paying attention?
yeah, exactly. Yeah.
Rachel, can I ask what made you guys decide to try guanfacine?
Yes.
I know I'd come to the lab and everything, but I've never really asked that question, because if you think of back to mechanism, was there something about the mechanism that you knew part of the brain?
Yes. So part of our prior research that was looking at the circuits within this cognitive biotype, as I might have mentioned, is that we saw dysfunction within the cognitive control circuit, right? So dorsolateral prefrontal cortex, DACC specifically. So guanfacine very selectively binds to alpha-2 receptors in the dorsolateral prefrontal cortex specifically, right? And that, like I mentioned, the animal data had suggested not only did it selectively bind, but it increased network connectivity and activation. So if you think about it, it was sort of a lock and key, right? So if we are thinking that this dysfunction in the circuit is what's driving the depression, then we need to be treatment forward with cognition. We've got to treat that dysfunction, treat the cognition, and ergo the depression will get better. And what's exciting is that's what we saw. Yes.
With the dosages that you use, did it cause any lowering of the significant lowering of the blood pressure?
Great question. So I will say we had a couple of participants that didn't make it to the 2 milligram goal because of this, right? So guanfacine is an antihypertensive, meaning that it lowers blood pressure and heart rate. And sometimes people feel this, they get dizzy, they get tired, fatigued. Actually, one thing I forgot to mention is Angela, I believe, maxed out at 1.5 milligrams, not even 2 milligrams, and she still saw improvements. So the sample was too small to see if it's dose dependent necessarily. But I will say we did not have any participants drop out or stop the drug due to orthostatic hypertension, which was wonderful. Hypotension.
I'm interested in the specificity of this treatment. Have you tried the same drug on patients with a different type of depression?
Great question. So as far as our lab trying guanfacine, we've only done it prospectively for these patients, right? So that was the whole point of this trial. Can we identify these patients and test it out on them, right? I will say that guanfacine anecdotally is used in the field for people that have anxiety. There's a high overlap between anxiety and depression. And what I've seen clinically is that it's not really remarkable as an antidepressant when it's sort of just generally prescribed. That was one of the reasons why I was so surprised to see it very successful in this scenario.
It'd be nice to see in those other patients what the functional MRIs would show.
Absolutely. Absolutely.
Thank you.
Yes. And then I'll go back.
Will you be including older adults in the trial? And I thought I saw in some of the other studies in the lab it was capped at age 75, but we also get people in their 80s and 90s who are depressed.
Yes. So for the Ph.D. trial, so our big randomized trial that we'll be rolling out, I believe we are capping at 65. That was sort of the constraints of the grant. But this is an interest of our lab and something that we're dedicated to. So I think the idea would be is if we can, get some good data for the 65 and under crowd, then let's move on to senior populations. But yes.
Has there been any interest in trying to use fusion tractography to see whether the area connects to, see where you're getting at by, treating that area? I mean, at least argue the fasciculus connection to the mesial and anterior temporal, as well as unsmooth to the supraorbital. So, which is getting treated?
Yeah. I love your question. I'm not going to pretend to be an expert within that methodology, but if someone is in the crowd, which I am sure there is, if you could raise your hand and then this lovely individual could find you after. Oh, great. I'd love to meet Jennifer. Sounds like you've talked to Jennifer.
Just read a receipt.
Oh,
Okay.
this brings up a great point that I forgot to mention. Actually, quite a few of our participants wanted to continue this medication, which was great. So we worked with their psychiatrist with this, so they were able to just transition. And we hope that with our future trials treating other biotypes with different medications that we're able to do the same. And that's one of the beauties of repurposing existing treatments. We did have some patients wash off of it. Unfortunately, because of the constraints of the study, we couldn't follow them for a very long time. I think that would be one of the hopes in our future trial is being able to do a 6-month check-in, right? Oh, do you want me to cut it off or one more? Last one? Okay.
It sounds like possibly just not but I didn't want to see any physicians similar condition, the ADHD from this table. And then two, would this more or less
We would love to know that. Like I mentioned, unfortunately, that was not in sort of the constraints of our design. I think what would be interesting about stimulant medication is, interestingly enough, that was not really on these patients' radar, and none of them had tried stimulant medications leading up to that. We also had quite a few patients handle or be struggling with some anxiety symptoms in addition to all of this, right? And so there's a concern with adding stimulant medication to that. The delineation between ADHD and the cognitive biotype will definitely be a subject for future research.